Welcome back to Health Policy Off Script. I am Matthew Hart from Longwoods. For healthcare umbrella organizations, finding the balance between supporting your community, your healthcare providers, and your relationships with the government can be a daunting task. The Ontario Alliance for Healthier Communities plays a vital role, and it is more than just primary care. How do they influence policy, support equitable healthcare, and create lasting partnerships? This is an interesting discussion on how we move forward and support each other. Today's session will be led by Dale McMurchy with guest Sarah Hobbs. Enjoy.
I'm excited to have Sarah Hobbs as our guest today. Sarah is the CEO of the Alliance for Healthier Communities, an umbrella organization for member centers that are community governed. Members include community health centers, family health teams, nurse practitioner-led clinics, the Indigenous primary health care organizations, and many other organizations that are coming on board to provide services with an equity lens in primary care. Full disclosure, I was also on the board of the Alliance and on a board of a member center and have done lots of work with the Alliance over the years in terms of research and policy. Welcome, Sarah.
Hi, thanks for having me.
One of the things I think people aren't as aware of is what makes the Alliance unique in supporting its membership.
So a couple of things. One is the fact that we are, as like any provincial organization would be, supporting our members by providing them education, providing them supports, providing them tools, resources, advocating for financial supports, advocating for the work that they do, advocating for making sure that they have the right compensation structures and things like that. At one point, we were about the model, like CHCs. We represented CHCs. And then over the years, we expanded that to other organizations that were community governed. And in 2015, we really named the fact that almost every single one of our organizations was working to address a health inequity in some sort. So that might be in a downtown urban center advocating, serving people that are new to Canada. It might mean in a rural or remote area serving folks that are, geographically distanced from healthcare and don't have the means to get to where they need to go and all of the different things. So the health equity issues that our members were addressing were different right across the province, regardless of the model, but that unified them. And so they recognized and they tasked us with this double function in 2015 to be playing that secondary role. We call it equal. We make sure that we're quite balanced in doing both things. And that is to advocate for health equity in public policy, in funding decisions, at every sort of level of the provincial infrastructure to make sure that if we get that right at the provincial level, then they can do their jobs better and they can make sure that they're meeting their missions, visions, and values themselves. And then the other thing that makes the Alliance, I think, a bit unique is the way that we have adapted and embraced, and as you know, the learning health system. And so we're able to use data. 20 years ago, the executive directors at that time, which I was one of the member centers at that time, made a decision to own the data that CHCs, and then of course other members that have joined since, the CHCs are gathering, producing, sharing. And so we have a collective electronic medical record. And then we also have a repository that on nightly uploads, downloads, feeds, I don't know, there's technical terms, that information goes into a repository. And then we're able to use that data, obviously, for reporting and for other things, but we're able to connect it widely. It's the biggest, I think, of its kind in Ontario, this network of primary care data, and it has sociodemographic and race-based data, so that's also quite unique. And it has a full team. So the whole team provides information into that electronic medical record, including health promoters, including outreach workers, including dietitians and social workers and the clinicians, the nurse practitioners, physicians, all the people. So that has enabled us to use the data to tell the story of the organizations, but then also be able to adapt and integrate a learning health system approach. And so that includes change management supports, it includes coaching, it includes all kinds of different supports so that people can be using data in real time to improve their practice and improve their offerings to clients. So I think those are sort of the things, and of course we got a research arm and all of that, but I think those are the things that bit unique. They're assets that I think other folks don't have.
You've got the recommendations, and then how do you make sure they don't go into a black hole? Do you get in front of the minister or the deputy or the ADM or the director and like what does that look like? And some comes to fruition and some is really frustrating, right?
Influencing policy is not always easy, and sometimes it takes longer than we would hope. And in addition, sometimes we can't see the influence right away, even though we might be making that influence. We do it with a multi-pronged strategy, but I think that what has been effective for us is using a multi-pronged strategy where we are working with our members to give them the tools to do advocacy at the local level. So we have done a lot over the last 2 or 3 years to think about how do we build our member centers' capacity in government relations. And that means providing them with learning opportunities, bringing experts in to give them the skills and tools required so that they feel like they and their board chairs and their boards can be involved in that local advocacy, whether that be with the federal, the provincial, or the municipal level. And we've seen some movement on that. Often, if MPPs are hearing things from their constituents and then they go back into government, and if it's been an issue that they've heard in a consistent and clear way, it sometimes gets back to government as an issue. And I think that we had some success around that with when we worked collaboratively across 10 associations for the For Us For You campaign, which did result, I think, in some increases to wages. Not enough, and we know that, but some increases that we're super grateful for. And so that's been one strategy. The other strategy is to bring our members together and get in front of MPPs in a Queen's Park lobby day. And this year we've taken a different approach. We're not asking for money outright, but we're asking for policy changes that'll make things easier for the folks that our members serve and easier for our members. So we're trying to be a solution-focused advocacy arm. And then we work with the bureaucrats. And this is where I think we have a lot of opportunity to work in collaboration with other member associations across Ontario. So we have something called the Primary Care Collaborative, which represents 6 associations in Ontario that work within primary healthcare. So that includes the Association of Family Health Teams of Ontario, the Nurse Practitioner-Led Clinic Association of Ontario, the Indigenous Primary Healthcare Council, the Ontario College of Family Physicians, the Section in General Family Practice as part of an OMA, and then us. And so we work collaboratively on areas that make sense for our joint membership to think about how we present ideas or how we present solutions to bureaucrats, to decision makers in Ontario Health and to the Ministry of Health and to the Primary Care Action Team, which is also known as PCAT. And that is led by Dr. Jane Philpott. It is something that the government put in place a couple of years ago to ensure that everybody in Ontario, they've got a lofty target of everybody in Ontario with a health card gets attached to a primary care physician or nurse practitioner and has an ongoing documented relationship, and they're meant to be doing this by 2029. So we've seen some investments, and this has been under the leadership of Dr. Philpott. So using all of those things, that's how we try to make policy change happen.
Can you give a concrete example? How is it that the Alliance or you and with your partners are making and influencing policy?
I think that I'll use a couple of examples. And policy is a big word for a lot of different things.
Yes.
Policy technically could be legislation. So we saw the introduction of the Primary Care Act for the first of its kind in Canada. And that was again under Dr. Philpott's leadership and with the Minister of Health being very committed to having this act. And we are thrilled with it. It's exciting. And we're really excited to see how the regulations come into being, which we're hoping to influence. Policy can also look like things at the local level. If we think about we have something called the Community Financial Policy, which is the rules of engagement for how our member centers and other community funded organizations like mental health organizations, community support organizations, how they operate on a day-to-day basis with their funding. And so, for instance, they had a stipulation saying that any capital expense over $5,000 needed to get pre-approved That is a long time ago that $5,000 was a threshold that made sense. We asked to be part of that review process. We were on that committee. We changed that to $25,000. So that's another way that policy is influenced. There's also how things are thought of, how things are designed. And so that's where I think that those position papers where we put them in front of decision makers and we see elements being pulled from there and it gets into the design of things. When we're thinking about the interprofessional primary care expansion that has been underway for the last couple of years as a primary care collaborative, we've had the opportunity to provide feedback on how those expressions of interest have come to be, what they look like, and we've seen changes. So we've seen changes from each EOI process where people have taken our feedback and changed the process based on the fact that it didn't work for all of our members, or there was some confusion, or it wasn't clear on how it should run. So there are times see our advocacy be a sort of straight line win, but most of the time it's not as easy to see, and it's bits and pieces of it that we see moving forward, and we think with our partners it's been a success.
Right now is really not the high point of focusing on a health equity approach to delivering healthcare, let alone primary care. That's a tough one for an organization whose mandate has equity flashing in bright lights. How are you stick handling the need to support your members and where things are currently in Ontario and across the country in terms of an equity focus?
Yeah, it's interesting. As I reflect on my time at the Alliance, I've been in this role since 2020, and at 2020 we were at sort of a peak of commitment to health equity after having gone through the pandemic and seeing how people fared through the pandemic in really inequitable and obviously inequitable ways, and there were other things in the world context that were happening that felt like people had that focus, and we've seen a step back from that over the last couple of years, which is discouraging. But I think for us at the Alliance, it means that we are, for the most part, trying to buckle down and not necessarily be apologetic for our commitment to health equity. At the same time, we're working with a government who's got a clear mandate and are making decisions that maybe our members might not always agree with, that the Alliance might not always agree with, but we need to work with this government. So sometimes being at the forefront of the issue hasn't been how we've worked on this. We've worked behind the scenes in different kinds of ways. So in the past, we might have been at the forefront of an issue, but now we're trying to be strategic in making sure that we stay at the table. We don't want to lose our seat at the table. And that's been hard. It's been hard for us as an association, I think, and it's been hard for our members as well in some respects. At the same time, I think that what we're trying to do strategically is to demonstrate, at least in the area of primary care expansion, there's a lot of other topics where we're taking on other strategies, but in the area of primary care expansion, interprofessional primary care team expansion, the way that we're trying to approach it is that we can have both. That we're trying to put forward solutions whereby we're meeting those attachment targets, but also thinking about it from a health equity lens. And we've done that through a couple of approaches, some I don't want to call them models, but approaches to how we do this expansion that accounts for both, so that we don't have to give up our health equity at the local patient level.
And there has been a narrative, and perhaps lesser so, but still, that community health centers are too expensive and they're inefficient. How are you countering that narrative?
I'm hearing that a little bit less, which is good. But over the last couple of years, there was some research and some evaluation done. I don't want to just say it's not true. I mean, I think that if that was the narrative, then we wanted to be able to address it, and so we did some digging to find out where the truth is. There's always a middle space about where that truth is, and we did do some analysis around looking at how teams are funded, trying to really compare apples to apples. For the most part, we're compared to family health teams, so I'll just talk about that in this moment. And so we looked at family health teams, and community health centers are funded a bit differently in that they have salaried physicians on their teams. And so that physician dollar goes to the community health center. Whereas family health teams, they have affiliated family health organizations that the family physicians gather into a group, and then they're affiliated with the family health team. So that physician billing dollars goes straight to the physicians and not to the family health team. So when we remove that, we remove the physician funding, or we added in the physician funding, however we made that equalized, and then we looked at the complexity. And when I talk about complexity, I'm not just talking about medical complexity, but I'm talking about mental health complexity and social complexity and how those layering effects. When we look at that, then they actually are on par in many ways. And so we did do some papers to try to shift some of that narrative. And I know it still exists to some extent, but also, I mean, we have to think about the fact that if you do want to serve folks from an equity lens, for doing it right, technically it should take more time and it should cost more.
The other thing Alliance members have done in community governed primary care is kind of work beyond its mandate. Can you elaborate a little bit on how you've opened the doors to the teams, for example, and worked with partners?
Yeah, I mean, we did a survey. I love this survey, and I think it's out of date, and we should probably look at it again. But a few years ago now, on average, CHCs across Ontario had more than 100 partnerships. So that meant that some had more and some had a few less because it's an average, but 100 partnerships working at the local level in all kinds of different ways. And many of our members offer all kinds of programming services. So they don't just receive Ontario Health funding for primary health care, but they also receive early years funding. They receive MCSS funding. They receive mental health and addictions funding. They have municipal funding, United Way funding. They have all kinds of programs and services that include things like partnering with their local food bank and different kinds of things to address the social determinants of health. And I think the most interesting thing about our members, and I don't know if it's unique because I've been in the sector for so long, but I think it's kind of unique, is that when you've seen one of our member centers, you've only ever seen one of our member centers because they are so hyper localized to their local context. And what that means is that in one community health center, they might build a whole programming and service partnership with others, and then also their own services around a seniors population. And then in another space, another community health center or family health team, it might look completely different. So I think that's really exciting. The thing that we've been embarking on recently is looking at how our members are partnering laterally. They have been partnering vertically with all kinds of organizations for years, and I just referenced that. But partnering with other primary care providers, and it happened, but it wasn't the norm. And so we have really tried to encourage our members to look at this as not a competition, and in fact, a collaboration. I'm very pleased to see that many of our members have embraced that, and they are now working through this expansion with FOEs and FITS and
family health organizations.
Yeah, so thank you. Sorry,
Yeah.
my acronym uses. So family health
Right.
organizations, so that's groups of doctors.
Without teams.
And yeah, without teams, and then also with solo practice physicians and nurse practitioners, like all kinds of different folks in their regions. So it's an exciting time.
And I think one of the things that the Alliance members have done is that when you mention the partnering with solo physicians, is we want to move to an interprofessional team-based primary care for everyone. So Alliance members have opened the doors to their teams to solo practitioners. Yeah. And that's been highly successful, hasn't it?
Yeah, so they did that. They started that, I want to say 2016 or even earlier. They started something called Team Care. And some organizations were funded specifically to do it, or some were just doing it. And so that's where you're connecting with physicians or that don't have a team attached to them, and they're able to get access to the teams that are provided by the professional primary teams. With this new funding, there's even been more of that. So and now what we're encouraging, what we're talking about is the neighborhood health home model, which takes all the idea is that every single nurse practitioner, physician team in a geographic area comes together and they figure out what their assets are, what they're good at, what they could do if they had more resources, what more resources they need. And then those EOIs include all of that. So it might mean a physician saying, I need a social worker once a week, and I need a clinic reception 3 days a week to help me bring on more people or to help serve my people better. And then they're able to ask for that in the expansion. So we've done that in a couple of ways over the years, but we're really seeing it work really well.
Sometimes there's, take the plunge and ask for forgiveness later, and then there's times where you sort of form the policy and go along for the ride and work with it. What's the balance?
This is an interesting question because I think that our members as a whole have had a changing view on risk and risk adversity and risk tolerance. And so sometimes I think in the past, we have been in a space where, and I remember it when I was the executive director of a member center, where we would have a funding letter. We'd get notification that we're getting funding. We'd have a funding letter. Then we'd wait for the funding to come into our bank account. And then we'd do the hiring and the announcing and doing the things. Those days are gone that we can wait. And so like, that's just one example where I think that my advice to members is like, take more risk, figure out the issues later. I think that on an operational level, there are times where my advice to members, and of course it's always their own independent decision making because they're all individual organizations and they all have boards to report to, but there have been way more times over the last couple of years where I'm like, we need to be ahead of this. This is the right thing, take the risk, do the thing, and then we'll figure out the consequences later. And it has worked well for our members, I think, that they're seen, for a lot of them, they're seen as leaders, and there hasn't been too much blowback on being bold. So I'm really proud of our members for that. And I'm proud of our members for shifting and changing with the times. I think that also with this government, it's important to stay aligned with their priorities and things. So when we talk about bold, we also don't talk about things that would risk the reputation of our member centers, or I would never want to do anything to jeopardize our member centers' relationships with decision makers. So we're careful about that. But we really are trying hard to be solution driven and to provide solutions that decision makers can get behind. And we're doing that through research, we're doing that through data, we're doing that through position papers, and then we're trying to make a compelling case. So I would say that it's a fine line and a fine balance, and we seem to be navigating it okay.
So Sarah, if you were in charge of healthcare in the province, what would you do? What are the 2, 3 policies that you would introduce first?
So I think that question is a little bit loaded because like there's dismantling an entire primary care system and starting from scratch that would make true transformational change. I don't think that that's helpful in this moment. So what I'm going to talk about, I think, are some approaches to primary care transformation that I think are actually doable within the systems and structures that exist. I would love to tell you my bold, big answer on the other thing, but I'm going to focus it on things that I think are actually, if I went in there and did that today, it would work. There's a couple of things that we're advocating for right now, and so if I could wave a magic wand, I would want to see it happen. And one I alluded to is the neighborhood health home model, and this is really changing primary care from looking at opportunities as a competition versus looking at opportunities as a collaboration. And so I started to talk about this. The neighborhood health home is an approach whereby nobody needs to change their governance structures, nobody needs to change their funding, nobody needs to look at their own individual organizations in any way other than how are we going to work together collaboratively to serve the people that we need to serve in the geographic region that we're in. And so I mentioned about, I see Ontario Health or Ontario Health teams coming together as conveners to bring all the primary care providers together to talk about, as I mentioned, who has what skill set, what do they need to be able to do things for their community, what will they need to attach more folks, what will they need to make sure that they're serving those folks that face barriers. Then I think we need a centralized intake person so that everybody can be matched with the right team that they need. So if you've got somebody who is Francophone and you have a Francophone organization, that centralized intake person will be ensuring that that person is being matched with the right team instead of a team that doesn't have French language capacity. And then the other core component to this is looking at this as an ongoing process, not just while we're in this moment of attachment, but coordinating on a regular basis, looking at patient needs, looking at influxes, looking at things, and redistributing as needed. The other piece that I think is important is the link worker position. This is, for some folks, you might know it as social prescribing, but for us, it is a position that if people have access to them, they can make sure that everybody is working to full scope of practice. A link worker is it's non-regulated, it's somebody who understands the community, and a physician, nurse practitioner, anybody can make a referral into that link worker. And that link worker will work with the patient. It's where they change the question from what's wrong with you to what matters to you. And this is where we can address the social determinants of health. We can address the sense of belonging. We can address living at home and aging in place. We can address all kinds of different things that will help people with their physical health, but is not actually the right thing for the physician or the nurse practitioner to be doing. And we've done some evaluation where if for complex folks, if the physician has access to a link worker, then those people are seeing a physician 40% less because they're seeing the right person for the right time.
Right. I'm going to challenge you a little bit on your health neighborhood model. I would suggest that there are probably opportunities across the province where there are mergers, or there is collaborative governance. And so that some of those organizations, some may merge, some may actually work much more in parallel where they share administrative, back office, clinical staff. And so that there's less of a brick and mortar feel. We're looking towards a bit more fluidity within that health neighborhood and maintaining the flavor of each organization, but gaining effectiveness and gaining efficiencies across the board at the local level.
I don't deny that that's not happening or that that's not important. It's not a mandate of the approach that we're saying. Like, it's not like we're not putting a stake in the ground that needs to happen, but we're seeing it happen. We're seeing folks collaborate in different kinds of ways that make sense to them. I think that the model is like a hub and spoke model, and the hub is not a physical location. It is just a practice, a team that sort of is helping to coordinate all those things, hiring the link workers and deploying them to different parts of the system, that kind of stuff. And so, but we're seeing that the spokes have some specialty, right? Like, so the spokes have some, some folks are serving walking well and can attach way more folks, and some are serving communities that face barriers. And so I don't deny, Dale, that doesn't need to happen or shouldn't happen, but it's not something that we feel is something that we would say is necessary for this approach to happen, especially if you think about rural Ontario or Northern Ontario, where geographic diversity and distance is an issue. Sometimes those kinds of brick and mortar mergers aren't feasible, but for sure, different kinds of supports and being supported in different ways. And there's one other element that I'd like to layer onto the model. Like, I think that if I could make another decision, so if we had every region working within this neighborhood health mode and really getting out of collaboration, unfortunately, we saw some processes through the last expression of interest where people were being sort of told to compete for funding, and we feel like that's not the right thing. So this model would get rid of that competition. And the other side of things, I think, as an additional layer to that, is thinking about complexity, and thinking about complexity not just as medical complexity, but thinking about the mental health complexity and the social complexity as well. And right now, physicians in Ontario specifically, they have access to their complexity scores. They don't use them. They don't need to know them. And then the teams also have, especially CMCs, they have something called a SAMI score, which is a complexity score based on the people that they serve. And so if we were to look at regional attachment, so the OHTs and the primary care networks would have goals for their region, their geographic regional attachment, instead of just saying every team physician, a nurse practitioner has the equal number of people that they need to be attaching across Ontario, this would help us meet the equity goal. It would help us ensure that health equity isn't being compromised by targets that don't make sense for certain populations, but it would not jeopardize the attachment goals for the province of universal attachment. So if we could layer both those things on and have link workers deployed in a region, making sure people's working at full scope, making sure people are working collaboratively instead of competitively, and then having OHTs and PCNs with OH's help, Ontario Health's help at the regional level, thinking about that broader attachment based on complexity. So if we've got physicians that are surveying people that are not as complex than the average in Ontario, they would see more people. They'd get more money for that. That would be great. And if we've got people who are receiving folks that are, more complex socially, medically, mental health-wise, then they would see less, and the right kind of care would be provided at the right time.
Thank you, Sarah. Thank you for joining us and giving us a ton of food for thought.
Perfect. Thank you so much for having me.
Thank you.